Jeff, we had a rectal temperature of 41 degrees Celsius.
Okay, so the patient's hot. I think that this is most likely due to a toxicologic cause, so we should start cooling the patient as soon as possible. So why don't we just start misting the patient and turning on the fans?
Do you want pads on? I noticed they're quite tachycardic.
Yes, we should. So let's just quickly review the vital signs.
The
Patient
is now having a seizure.
Seizing?
Okay, patient seizing.
I have Ativan here.
Yeah, so let's give Ativan 2 milligrams IV. Hi, I'm Dr. Jeff Yu, a board-certified emergency physician in both the USA and Canada, and this video demonstrates a simulated resuscitation of a young patient presenting with status epilepticus and severe hyperthermia. This scenario was inspired by a series of real patients treated at our hospital over the past couple of years, many of whom had tragic outcomes. And this simulation is performed by me and my real emergency department colleagues, including nurses, respiratory therapists, and emergency physicians that I work with in real life. The case is run in real time in a single take and is completely unscripted. Nothing has been removed for the sake of brevity, and because of that, mistakes are expected and they're valuable learning opportunities. The purpose of simulation is to improve together as a team so that when we encounter a critically ill patient in real life, we're prepared to perform at our very best and give that patient the greatest possible chance of survival. Simulation is designed to replicate the real-world stress of managing critically ill and dying patients, which can be really intense and triggering for both participants and viewers. So after the simulation, stay around for the debriefing session, which is often the most important part of the learning process. Let's begin.
So your team is in an emergency department in an urban center. And you've been notified about a female patient in her 20s who's going to arrive in about 5 minutes. Paramedics called for a pre-arrival. She was found confused outside of a rave tonight and reportedly used some substances. She was complaining of being hot when the paramedics arrived, and shortly afterwards she had a generalized seizure. The paramedics gave her 5 milligrams of IM midazolam. Post-seizure, she was post-ictal. Her GSCS is 8. She's not intubated. She's got IV access, and her ETA is about 5 minutes.
Okay, great. So since we have a couple minutes before the patient arrives, let's just quickly do a round of introductions with roles. So I'm Jeff Yu. I'm going to be the team leader for this case.
I'm Scott, one of the residents here at St. Paul's. I'll be the second physician on.
I'm Reed. I'm a respiratory therapist.
Moses, I'll be the monitor nurse.
Dave, I'll be the bedside RN.
I'm Anna. I'll be the nurse lead.
Okay, great. So I think we have everything here. So it sounds like the patient might have seized. It sounds like she's hot, a little bit confused. So I'm really concerned that the patient might be coming in with a toxicologic seizure, hot and bothered. So the priorities when she arrives is to get her hooked up to the monitors, get 2 large bore IVs as soon as possible. We might need to give her some cooled IV fluids as well. We'll get her hooked up to monitors, get a full set of vital signs, including a core temperature and a glucose. And we'll send off a full tox panel as well. So if we could send off like acetaminophen levels, salicylate levels, ethanol levels, along with rapid metabolic panels, so that we're getting that back as quickly as possible. And then Scott, when the patient arrives, maybe you can just start with a primary survey while I get collateral history from the paramedics, and we'll go from there. Is everyone clear? Does anyone have any questions or suggestions before the patient arrives?
Do you want any medications prepped ahead of time?
Yeah, that's a good point. Why don't we get lorazepam prepped ahead of time in case we have to abort any seizures. And in case the patient does need to be intubated, we can get propofol and maybe get succinylcholine and rocuronium prepared just so that we can, choose between the two, but we can discuss that when the patient arrives.
Okay, got it. So we'll get Ativan and the intubation medications ready to go.
Yeah, exactly.
Okay.
Great. Any other questions or suggestions before the patient arrives? No? Great. Okay, so we'll just glove up, get ready, and
Okay, so it looks like the patient's rolling in now, and they're coming in with a friend who can provide some collateral history.
great. Hello.
Hi.
Are you, what's your relationship to the person?
She's my friend.
Oh, okay, yeah, tell me what happened.
We were at a rave and we just took some like MDMA.
You can come this way.
I think some cocaine. and she just left somewhere, and she came back like unconscious.
Okay. Does she have any past medical conditions that I should be aware of?
She has anxiety.
Ma'am, my name is Dr. Bell. Can you tell me your name?
There's no verbal response, just a bit of moaning.
I'm,
Do you know what the name of that pain?
There is some rigidity in the jaw a little bit.
I'm looking in the airway. I'm listening to both lungs and the heart.
You're hearing breath sounds present on both sides, and the heart sounds are normal, but she's very tachycardic.
Okay. I'm checking her cap refill.
A bit delayed.
Okay.
That's through 93 and 4 liters.
I'm going to quickly check her eyes. What are her pupils? Is there any
Pupils are,
movements?
quite dilated, and you notice that there's clonus as well.
Okay.
Do you know if she was feeling sick?
Heart rate is 160.
Is she moving all 4 limbs?
She is moving all of her extremities, yeah. You notice that she's hyperreflexic when you check her reflexes. And you see some clonus there as well, inducible in the feet.
Okay.
Blood pressure 160
Well,
over 85.
it sounds like she's quite sick right now, so we're gonna do some investigations and start managing her. But why don't you have a seat in the waiting room?
I'll get the social worker too.
Okay.
Can I walk you up there quickly? Okay.
You notice that her skin's quite hot.
And she's sweaty to touch. Okay.
So can we just regroup as a team, and we'll just I'll quickly summarize what I got from collateral, and then you can summarize what you have from primary survey.
Okay.
So the patient's friend tells me that they were at the club, they used some MDMA and cocaine. Sounds like she's been taking tramadol for a recent dental surgery, and she's on, I believe, citalopram or some kind of other antidepressant or anti-anxiety medication. And it sounds like she went outside for a bit, possibly used some drugs, and then felt really hot and might have had a seizure. What did you find on primary?
So she's hot, she's diaphoretic,
4 liters.
she's got
Nasal
dilated
pump,
pupils with ocular clonus. She also has clonus bilaterally in her lower extremities.
1
She's
liter
hyperreflexic.
normal saline bolus.
Vitally,
Infusing. Thank you,
she's
Dave.
tachycardic, and she's on a few liters of oxygen, maintaining her saturations at 94%.
Okay. Okay. So guys, I'm really concerned that this patient might have toxicologic seizures. You said that she felt hot. You said we got a temp on her?
Yeah, oh yeah, we're gonna get a temperature now.
Okay, let's get a temp and a glucose as well. But the things that I'm concerned about are neuroleptic malignant syndrome, malignant hyperthermia, serotonin syndrome, meningitis and sepsis, anticholinergic syndrome, thyroid storm, sympathomimetics, and salicylates. So these are all the things that we need to be considering right now. I think we should send off a full tox panel.
Yeah, Jeff, we had a rectal temperature of 41 degrees Celsius.
Okay, so the patient's hot. I think that this is most likely due to a toxicologic cause, so we should start cooling the patient as soon as possible. So why don't we just start misting the patient and turning on fans?
Do you want pads on? I noticed they're quite tachycardic.
Yes, we should. So let's just quickly review the vital signs.
The
Patient
patient is
tachy.
now having a seizure.
Okay,
Okay.
patient seizing.
I have Ativan here.
Yeah, so let's give Ativan 2 milligrams IV. Patient is tachycardic and a bit hypoxic as well. So yeah, you can just assist her ventilations. And Anna, if you could just let me know how long the patient's been seizing for, just keep track of that.
Okay.
And let me know when 3 minutes has elapsed, and we'll give another dose of Ativan, okay?
2 milligrams IV administered, Anna?
Ativan 2 milligrams given.
Okay,
I'm gonna
so,
go get something to help start cooling.
okay, excellent. So patient's oxygen saturations are,
87, slightly coming up.
okay.
Do we have air
Are you-
entry?
You do have air entry.
Chest rise.
She's got good chest rise. I've got good air entry bilaterally.
Does she sound clear to both lungs as well?
Yes, both lungs are clear.
So it's just exposed here, Dave. Sorry, man. We're gonna need to take your clothes off so we can cool you down, okay?
It's been 1 minute.
Is she still actively seizing?
She's still actively seizing.
Okay, let's just prep Ativan 4 milligrams IV so that we can give that to her if.
In 2 minutes.
Yeah, just get that prepped and ready.
That's ripped in.
Andy, can you let me know in 2 minutes? Is that
Will do.
So the patient hasn't returned to her mental baseline between her first seizure en route to hospital and this one. So I'm concerned that she has status epilepticus. So we're currently in the status algorithm as well. So we'll give, if she's still seizing in a couple of minutes, we'll give another dose of Ativan. We should also call pharmacy and ask them to send up Keppra 2 grams IV.
Okay, we'll do that, Jeff.
Okay, excellent. Can we also, Dave, do you mind just grabbing some medications for intubation as well?
Sure. What medications do you want for intubation? Can you just remind me?
So given that the patient is in status epilepticus, I think that we should probably give propofol as the induction medication because that will cause burst suppression of the seizures. And I think for the paralytic medication, because we don't know if this patient's in rhabdomyolysis, we don't know if she has neuroleptic malignant syndrome or malignant hyperthermia, we probably should not use succinylcholine. Even though I think we should probably use rocuronium, even though there is a risk of possible subclinical seizures with the rocuronium. But yeah, why don't we drop propofol 150 milligrams and rocuronium 150 milligrams as well.
150 milligrams of propofol and.
Okay, so it's been 3 minutes. We can give 4 milligrams of IV Ativan.
Okay, let's do 4 milligrams IV Ativan. Just let me know when that's done. Dave or Moses?
Yeah. Dave's going to get that.
Can you remind me of the...
Now, if we're prepping to intubate, do you mind taking
Yeah,
the bag?
I can take the airway.
Yeah.
150.
Letter and title.
The patient's still
milligrams IV
seizing.
4 milligrams
Okay, so
IV Ativan administered.
Patient
Thanks,
is still
Dave.
seizing, so we should definitely prep for intubation. Scott, if you want to just work with Reed and just get all the equipment ready.
Yep.
I'll just quickly summarize the case while we're getting prepared.
Perfect.
So we both have status epilepticus and we're in kind of like the active cooling hyperthermia algorithm as well.
Is that a 3?
We think that this is most likely due to serotonin syndrome. She does meet a lot of Hunter criteria for serotonin syndrome with the ocular clonus, with the agitation, confusion, and the inducible myoclonus as well. So can we also call the the poison control
Poison control?
center and
Okay,
just
will do.
ask them for advice? Like particularly, if you could just call them to ask if we should be giving ciprofloxacin, that'd be great.
So the seizure has aborted, but she's still very obtunded.
Okay. Okay. Well, we should definitely proceed with intubation as well.
Intubation meds are prepped.
Okay. Did we already give Keppra 2 grams IV as well?
We have not. No,
It's
we
coming
just
from the
gave-
pharmacy.
Coming from pharmacy. Okay.
6
If you could just let me know when Keppra arrives, that'd
Okay.
be great.
Good. OPA's in.
OPA's in.
Okay, is in. Okay.
So we go 3L to 3. Blade.
So let me know when you guys are prepped and ready to go. We'll do
Sure.
a quick pre-intubation pause to discuss the plan.
Okay.
Dr. Bougie and LMA, or iGel as backup.
Okay.
7.5 tube, started.
Fantastic.
Satura's still
Satur.
90.
See if I can bag her up just a little bit for those saturations.
Yeah,
Doesn't look-
it's weird that her O2 sats haven't come up at all. Okay. So her sats are kind of, you're bagging her, she's got good air entry.
Still have good air entry.
Okay.
Did we already give cooled IV fluids as well?
We have not. No.
Okay, can we make sure that we're giving her cooled, we have normal saline hung, so why don't we give cooled NS to start? So for cooling, we have the fan on. We've already covered her in water. She's got ice packs in the axilla, her groin, and we've got IV fluids going. I think if the patient is still hyperthermic, despite these measures, after we do the intubation, we should consider escalating to
1 liter
ice water submersion.
Jeff, we bagged her up to 95 here. Whenever you're ready, we're ready to proceed with intubation.
Okay. And how frequently are we repeating that blood pressure?
We're repeating it every 2 minutes.
Every 2 minutes? Okay.
So the Keppra is here from pharmacy.
Got it.
Here you go.
Yeah, and I just checked the blood sugar, it's 5.5.
5.5? Oh, perfect. Okay. So we'll hang Keppra as well. What do we have for IV access? Is it just
We have two 18s.
two 18s? Okay. So we'll hang Kepper on one, and we'll use the other line for the rapid sequence intubation.
What's the Kepler dosage?
2 grams IV, and you can just give that over 15 minutes.
Poison control has called back and said that we can go ahead with ciprohepta, I believe, when the patient is intubated and stable.
Okay. So I think that will be a lower priority item. I think for now,
I will just continue to document what the recommendations.
that'd be great. Thank you.
Their priority from poison control is actually, once she's stabilized with intubation, is rapid cooling is what they suggest.
Okay.
Kepler 2 grams IV.
Keppra 2 grams
infusing.
IV.
So I think the main priority after intubation is to get her temperature below 38 degrees within like 10-20 minutes. Like I think that's the most important thing.
We are at 7 minutes.
At 7 minutes?
Yeah,
Okay.
since the seizure.
Do you want me to get ready for like submersion?
Yeah, if you could get ready for submersion while we do this intubation, that'd be great.
Sure. Yeah, I'll do it like that.
Fantastic.
Are you ready to go?
I'm ready to proceed. We're just doing a quick timeout here, a sterile cockpit for the intubation. So we have a young female here. She's unable to protect her own airway. She's had status. We're going to be securing that with her. My primary method of operation is going to be a video laryngoscope. We have a bougie as a backup, and then we have number 4 eye gel on the way back. We have intubation meds drawn up. We're going to be using propofol 100 as well as rocuronium 100 for our RSI dosage. We have a patent IV currently flowing. We've got monitors with a cycling BP cuff. We have RT for support, and I have a 7.5 ET tube with a stylet in. I'm happy with this bed height. I'm going to just actually optimize the position just by dropping her head maybe about 10 degrees or so. We have a nurse at the bedside ready to push the meds.
We do.
Okay.
Start off with the propofol.
If we can start with
Vitals
the...
look great too.
And what dosage of propofol?
We can start with 100 of propofol. And you can just...
So Scott, I'll watch her vital signs while you do that, but right now her vital signs are optimized.
And
Fantastic.
100 propofol. administered.
100 milligrams of IV propofol
And
given.
we can
Thanks, Dave.
follow that with 100 of rocuronium.
You want to trade?
And if someone can just set the timer for 45 seconds.
And 100 milligrams of rocuronium.
100 milligrams of rocuronium given.
Has while he does that, have any of the blood work come back from
Sensor
lab?
hit, 96.
You are getting some initial labs back.
Excellent.
Okay.
We should also call for a stat 12 lead ECG as well, because I want to make sure that QRS is not
Good.
wide.
Good.
I'll call. Can I please get
And
BCG
10 seconds.
pre-trauma? Okay, we're near 20 seconds now.
Okay.
The patient is slightly hyperthermic.
Go in. I appreciate the cords. I've got a grade 1 view. Going to retreat to a grade 2. Okay. Could I get this? Could I get this started out at about 2 inches? Thank you. And all the way out. 1 second.
Perfect. You're happy with that too?
Give me 1 moment. It's just caught up on the cords.
In the cords.
In the cords here. Just
If it's through the
Yep.
cords.
through the cords
the
here.
cords.
Perfect.
Half
If we
step.
can up. Fantastic. So
And
23 at the
vitals.
tooth.
So vital signs are still
Sorry,
stable.
how much at the teeth?
23 at the teeth.
23 at the teeth. What size?
It's a 7.5.
7.5 French. Okay, thanks.
She's got good orange
Got
bilateral.
bilateral air entry.
Okay. And
Hold
let's
that.
check the end
And
tidal
vitals
CO2.
up, 32.
Okay, good. So got good end tidal CO2. Vital signs are still stabilized. So Dave, if we could just get propofol going, let's start at 50 mics per kilogram per minute and target a RAS of -4 so that we're actually getting burst suppression of those seizures.
What's her weight?
Let's
Estimate
estimate
60.
60
60
kg.
kilograms. Thank you.
So I'm just going to summarize what we have on the blood work, and let's call for 12 lead ECG to be performed right now as
I
well.
just called.
I'm just gonna put it
They're here.
So the patient has significant acidosis with a pH of 718. Her lactate is 10, bicarb is 14, so she's got a really bad metabolic acidosis.
Prongs off after.
E2H is 20, salicylates are negative, Tylenol is negative. The rest of her blood work looks reassuring. And she has a little bit of hyperkalemia with potassium of 5.2.
How much did you want the propofol to be infused?
And her ECG shows just sinus tachycardia at a rate of 150, narrow complex. There's no wide complex cuirasses, so I don't think that she has any kind of sodium blockade or TCA or anything like that. So that's reassuring. Great. So can we just repeat a core temp as well?
Yeah, we just put in an esophageal temperature probe, and it is now reading 40 degrees Celsius.
Okay, so she's still hot. We should we should escalate to the cold water submersion. So
Yeah, I got the bag ready for that. So
Propofol
we're ready to set up.
Okay.
Propofol infusing at 10 mics per kg per minute. Can we increase
let's
the
bump that
propofol?
to 50.
50? Okay,
Yeah.
Thank you.
Propofol now infusing at 15 micrograms per kilogram.
Propofol at 50 mics per kilogram per minute. Thank you, Dave.
Okay, excellent. So I'll let you guys dunk the patient in.
So, hey Reed, we're gonna need to roll.
Yeah.
You okay to, you got
sure.
the airway?
Yeah.
Okay, so on your count.
Okay, rolling on 3. 1, 2, 3.
Okay, you guys can come on back over.
Back down and 1, 2, 3.
And I'll roll this way if you guys can get the bag underneath. Good, come back down.
Yeah.
3, 2, 1. Alright. Zip this up a little bit, and then we'll. I got some ice just from our freezer outside, so I'll.
Did you want a Folian for a tox screen?
Yes. Yeah, that's a great point. Let's get a Foley in, send off for a urine drug tox screen. And I think also just to cover all of our bases, we should also give the patient broad spectrum antibiotics.
Okay.
So let's give her Pip-Tazo 3.375 and Vanco 1.5 grams as well, IV.
So Pip-Tazo 3.375 and Vanco 1.5.
Once you get that in.
Yeah, I don't think that we actually drew blood cultures the first time that we drew blood, so we should call phlebotomy and ask them to draw blood cultures
Would you
on
like
it.
any more blood work? Did you get a CK?
Let's get it. That's a great point. Let's
And
get
then
a CK
TSH?
and a TSH, and we'll let's also repeat the rapid metabolic panel, given that she's received a bolus of IV fluids as well.
14 French Foley inserted. Thank you, Dave.
So while the
Can I please
patient,
get lab to the trauma room?
while the patient's getting submerged, does anyone have any other questions or suggestions for what else that we should be doing?
Now that we have secured the airway, we can start putting in OG or an NG to give ciprofloxacin crushed.
That's a great point. So we put this temp probe, esophageal temp probe in. Does the patient have an OG in as well? Okay, I think after we get the patient submerged in ice, we should sink in OG so that we can give oral meds as well.
And if you want to call social worker just to see about family.
Oh, social worker is just with a friend right now, but I will connect with them
Okay.
to touch base with family, okay?
Tana, OG2 is equal to it.
If you have what size? 16 French?
You have to watch the lines and stuff. How far up do we want to fill there, Jeff and Scott?
Just make sure that his chest is exposed. We have defibrillator pads on right now as well, so if the patient does go into a life-threatening arrhythmia, we can still shock this patient while they're submerged.
Okay. Just want to watch over her skin. Take her as we zip it up, it'll contain it.
Right.
Yeah.
So we can zip it up, and then we can start adding some water.
Just lay on the bed a little bit. Can we just pull her over a bit?
Yeah.
On 3?
2, 3. There.
Can you remind me how much antibiotics do you need?
So PIP Tazo 3.375 and Vanco 1.5 grams. We're just waiting for a lab to come by to draw blood cultures before we start antibiotics.
No problem, I'll just start.
If there's a delay for phlebotomy, let's just give broad spectrum antibiotics just to make sure that we're covering sepsis as a potential cause of fermentation. And Scott, when you examined her, you didn't notice any like meningismus or nuchal rigidity or anything like that?
No, no nuchal rigidity on her, and no like Kernig or Brinsky sign. The limits of her exam, she was quite altered when she came in, of course.
We should call ICU as well. Just let them know that we have a critically ill patient that came in with status epilepticus and hyperthermia, and we're actively cooling.
I'll call the charge nurse.
That'd be great.
Yeah.
Do we? What's the temp reading right now?
Temperature reading?
40.5.
Still 40.5. Okay, so let's just continue filling that body bag. Any issues right now from an airway standpoint, or?
Bilateral air entry. I'll throw a bite block on in case she seizes again.
Okay. So one of the things that we'll have to watch for is if the patient starts shivering through the, I guess the paralytic.
Are we expected to actively stir the ice and the water around?
Yeah, you can stir it around so that it becomes a slurry. Can we also call neurology? Because I think we should probably get active continuous EEG monitoring to make sure that we're not missing subclinical seizures that are masked by the paralytics.
Okay, calling neurology.
Yeah, thank you.
ICU is aware, neurology and the intensivist will be coming down shortly.
Okay, excellent. Great.
Blood cultures have been drawn. 2.375 milligrams of Tazo was confusing. Can you remind me the dosage of the vancomycin?
Vancomycin 1.5 grams. Lab needs to also draw a repeat RMP and also a CK and a TSH.
Yeah, if you can just insert a third IV, and when you do that, you can just draw off labs and send that off to the lab as well.
And we'll throw her on the ventilator.
Excellent. Given that, do we have a Foley catheter in? That's Foley catheter's in? Okay.
Foley catheter's in.
So if the patient does not cool with this, we could consider cooled CBI as well for cavitary cooling. So maybe we can just like get the CBI equipment ready to go just in case the patient's temp doesn't come down. And the other thing that we could consider is asking the ICU to consider, possibly hemodialysis for, more advanced cooling. Are there any other suggestions that you guys can think about? I think the metabolic profile looked pretty good in terms of electrolytes, but...
Okay, can I please get a lab to the trauma room for a specimen collection?
So the temperature is now 39.8 and ICU has arrived.
Okay.
I think we can wrap up there.
Okay, excellent. Now we're going to move into the debrief, which is one of the most important parts of simulation training. During the debrief, the team takes time to process what happened. We discuss our immediate reactions, what went well, what could have gone better, and we also identify opportunities for improvement that we can apply for future resuscitations. We also spend time reflecting on human factors and system-level issues that may influence how a resuscitation unfolds. From my perspective as the team leader, one of the biggest challenges in this case was cognitive overload. I had to process the patient's history, clinical findings, recognize the combination of seizures and hyperthermia, and manage two time-critical problems simultaneously. And at the same time, I was coordinating team dynamics, delegating tasks, and thinking several steps ahead. So both in simulation and in real life, one of the best ways to manage that cognitive load is through deliberate delegation. Offloading tasks to capable team members allows the leader to maintain situational awareness and focus on critical decisions. Another key strategy is frequently summarizing the case out loud and actively inviting input from the team, and this helps to maintain a shared mental model. And as you might have noticed in this case, several important contributions came from team members speaking up. And this is exactly why we train this way. The goal of simulation is not perfection. The goal is to learn together so that when a real patient arrives in critical condition, the team can function as a cohesive unit and provide the best possible care.
So if you want to summarize a little bit before we start the debrief, I think that'd be a good place to start, and then go from there.
Yeah, so to summarize the case, we had a patient that had toxicologic exposure to street drugs, MDMA and cocaine, and she was already on serotonergic agents with tramadol, PRN for a dental procedure, and taking citalopram for an antidepressant or anti-anxiety medication. You know, she came in altered, had ongoing seizures. She was in the status epilepticus, so we were going down the status algorithm, but she was found to have hyperthermia, and so we started active cooling with the cooling algorithm as well. She was critically ill, and she needed rapid sequence intubation. I thought that, you know, that was quite fluid. Yeah, what are your thoughts?
Did you want to take the lead, or? Okay, so I guess we'll start with the Moses special of just mentioning that this is supposed to be a psychologically safe space, and it's just an opportunity for us to practice going through protocols of things that we see very infrequently using equipment. And today was an added an added snag of like this body bag and the ice and all the logistics of that. So I think that was awesome. But in the beginning, before we kind of go through the good things that the team did together and some things that we want to learn from, it's just a chance for us to kind of talk about our emotions and just how it felt going through the case. So I'll let anyone start.
Hot. It felt hot.
Hot. I felt cold.
What do you mean?
There's a lot going on. I think the patient was really, really sick, and obviously a lot of things had to happen quickly. So, and they were hot.
It felt chaotic but good, I would say. You know, we've had a number of fatal toxic exposures that we've seen at this hospital that presented very similarly to this patient, and that inspired this case. And I can say that I think many people here were part of those initial resuscitations, that they were very chaotic experiences. And so to be moving forward in trying to put what we've seen into making the department a more efficient, better place in the future is very rewarding, and really goes to show that just even running through in simulation can really reduce the stress, because as much as this was a lot going on, a lot of people, a lot of things need to happen at the same time with logistics, it was so much smoother than what it was in real life. And already you can see the protocols that we've tried to put into place, how much those can go and help when we really need it in these critical moments of patient care.
I think we were quite organized with looping back into our algorithms, so I really appreciated you just rerunning from top to bottom with what has been done and what we're doing and what we're anticipating.
It felt really fast. Things were rapidly changing. So it was like super dynamic. Things were changing like minute to minute, which is kind of reflective of real life. So it felt super fast to me.
Yeah, from a team leader perspective, it felt a bit chaotic because there's like so many different moving pieces. Like we're in like two separate, somewhat overlapping algorithms with the status algorithm and the hyperthermia algorithm. And there were just so many things that needed to be, so many bases that need to be covered. So I did appreciate like all of your thoughts chiming in, because there were some points that I missed. Like, you know, you mentioned some of the blood work that I missed on the initial lab draw, like the CK, the TSH. Those are obviously very, very important things, but it's just, you know, it's hard to capture all of those things.
And we're so focused in on what's going on at hand.
Yeah, because you're trying to absorb so much information from all the different team members while like thinking about these algorithms and kind of like directing the team and orchestrating this resuscitation. So that can be quite challenging. Yeah.
So I think that's a decent segue to go into some of the things that we think went well. So I'm hearing that teamwork was great for you, and people bringing up other points that you might not have been thinking about when you were prioritizing ABCs and all that other stuff. So I would agree. Anyone else want to talk about some positive things?
We try not to delay active cooling and intubation for other things like other minor procedures.
Like I liked how we were fluidly cooling the patient while getting all the other things prepared. Like while Scott was preparing for rapid sequence intubation, other team members were actively cooling the patient with the fans, the ice packs, and also like getting the body bag ready, getting all the other equipment ready so that we can actually escalate through that algorithm at the same time. So I felt like there was a lot of like, people were kind of branching off doing different tasks, but everything seemed to be quite coordinated, and I thought that we worked really well and fluidly as a team.
Yeah, it's dope. Well done.
And I'm glad you didn't just hone in on the drugs, like you still were ruling out like
Broad.
encephalitis, meningitis, and
Thyroid storm.
everything else.
Yeah.
Exactly, that could have been going on with the patient.
And I think in the beginning, you had a couple minutes to prep the team. So I think that roles being established was an awesome thing to do as well, just so the team was prepared and you even had a chance to get some of the medications ready before the patient arrived. So I think that was also a nice thing from a team perspective. So why don't we move on to
I'll come find you.
things that were maybe challenging, or things that tripped us up, or things that we think we can learn from this case.
I think one thing that we took away from this case and from the case that inspired is just that the management of ice is such a real challenge in the emergency when you try to use like an active cooling method. This is supposed to be deployed in a freezer, but I think even running through this case, we realized that just putting the ice in the freezer causes it to jam, and sometimes you can't easily deploy it, and you need to have some container to move it over. And I think that it just highlights that having a system in place to try and transport the ice, even when you're storing it, is super useful to the department. Yeah.
Yeah, so I don't know if you guys saw, but we have that big square freezer in our trauma bay now. And so even the ice initially was in 2 big garbage bags, and removing the ice from the freezer was actually a challenge that we learned about today. So probably we need to package it in several smaller ice bags.
Ziplocs or something like that?
Yeah, or like even the gas station bags I think would be sufficient.
Because I guess like if you put it in smaller bags like this size, you could also use those as ice packs, neck, axilla, groin.
Yeah.
Like that's probably one thing that, like I think that, you know those freezer bags for Ziploc?
Yeah.
I feel like that would be a really good size.
Yeah.
You can use them as ice packs, and then if you progress to using the body bag, you open it up and just dump it out.
Yeah.
And wouldn't stick because it would already like kind of melt a bit, right? Yeah.
I think something just to be conscientious of in real time is when you've put the ice in the bag and the active cooling has started, just being conscientious of like adhesive tapes that are holding IVs, all this and the other, because if they're not reinforced, if they're not protected, they're almost 100% kind of gonna detach.
So that's a great point, like putting as much on the patient as you can before they go in the bag. So pads on if you can, even so far as like ECG stickers and monitors, because once they're wet and they're in the bag, it's a lot harder to put those things after the fact. You'd have to dry the patient and then adhere the pads. So here you did put the pads on before they were in the submersion. So it's another point.
And it was really good because people have said, yeah, can we hold off for 10 seconds so we can get the Foley in, obviously, before we get this done. And I think that was a good pause, definitely worthwhile.
Another good thing, like Moses said when dumping the ice, was we'll watch the skin. Because if we're dumping icebergs onto the patient, we've got to cut them for sure. True. Yeah. So if it's broken up into nice little pieces, it's fine. But
When do we give the Cipro? I've never given it before.
Yeah, it's not a huge priority.
Yeah.
Especially like for someone who's this critically ill. So yeah, it would be something probably like once they have an OG and this stuff is dealt with, they're cool, they have ABCs, all that stuff. It can be done later, but it's not going to save this person. No. This person's like too ill.
Yeah.
Yeah, I think the biggest priority is to rapidly cool them in less than 20 minutes. You want to get their core temp below, ideally like under 38, but like, for sure under 40 degrees Celsius. Because I think if the longer they stay in hyperthermia, the higher their mortality rate, the higher chance that they're going to go into rhabdomyolysis, DIC, renal failure. So the main priority is to get that temp down super, super quickly. And like for sure, the quickest way to do that is ice water submersion. There's like really no other comparison, right?
Can I ask you a question from out of curiosity? Is there a risk of overshooting in terms of keeping the patient hypothermic for too long, just in terms of DIC or coagulopathies?
Yeah, I mean, there is, for sure there is a risk of iatrogenic hypothermia, like overshooting the target and getting them down below that temperature. But I think that's why it's important to have a core temp, like a continuous core temp in the esophagus, not in the rectum, because one of the biggest issues with keeping a rectal temp probe is it gets stuck in poo, and the poo actually distorts what temperature the actual body is in. So having an esophageal temp probe, which actually mirrors what the heart is feeling because you're putting that temp probe close to where the heart is, that's like the best indicator of like what the temperature is. And you know, when the patient gets down to the level of 36, definitely at 35, that's when you'd consider actually taking them out of the ice bath. And yeah, logistically that would be hard.
Yeah. So one thing that one of the toxicologists told me is that this is going to be so full of water and ice and slush, so you can cut the corner and then you can just dump it all out. The slurry would be dumped into a big garbage bag or into the sink, and then that's one way to like easily empty the bag, and then you would dry the patient. And at that point they're sedated, they're paralyzed, and you've sort of shut down that whole like process of the hyperthermia. So yeah. Great.
Any other points for debrief?
No, I think it was intentionally a very difficult case because there's like 10 things going on at once. And I think the priorities from the ED team were established, right? Like ABCs. And then getting, so in real life, we had a similar case where the initial temperature was not hyperthermic, in the hyperthermic range. I think it was 37.1 that it was reported as. So getting once you've recognized that this is a potential, so your exam kind of pointed you to this could be serotonin syndrome, getting a core temperature to kind of figure out what you're dealing with, like how severe is this toxidrome that we're dealing with. So I think I thought it was great that you guys got you recognized that you got an early core temp, and then you're like, okay, now we know what our next steps might be. So I think it was great. I think you guys did a good job.
Awesome.
Yeah.
Good job, guys. Yeah. The simulation was designed to demonstrate structured team-based management of severe hyperthermia and status epilepticus, and to help translate emerging practice guidelines into practical bedside care. And while protocols and scopes of practice vary between institutions and regions, the principles shown here reflect current evidence and evolving best practices in hyperthermia management. If you'd like to learn more about the background of this case, you can find a full written breakdown of the clinical context, relevant guidelines, and supporting evidence on my website at drjeffu.com/simulation. This is the second simulated resuscitation video in a series that we're developing to help medical teams train for the management of critically ill patients. Everyone that you saw in this video volunteered their time and expertise, and we're making this educational content freely available. If you found this video helpful, I'd really appreciate your support by liking this video, leaving a comment about other cases that you'd like to see covered through simulation, and subscribing to the channel. Thanks for watching, and I'll see you in the next one.